Good morning. Today I am going to take puberty and its disorder. Definition, morphological changes, endocrinology. These are the contents that I am going to take in this class. Puberty in girls is the period which links childhood to adulthood. It is the period of gradual development of secondary sexual characters. Morphological changes described by Tanners and the Marshalls. 5 important physical changes are evident during puberty. These are the breast, pubic, and axillary hair growth, height growth, menstruation. The most common order is beginning of the growth spurt, breast budding, that is also known as a thelarche, pubic and axillary hair growth, adnarche, peak growth in height, and menstruation, that is also known as a menarche. All these changes are usually completed between the age of 10 to 16 years. Now, what is the endocrinology of the puberty? Hypothalamic gonadal excess. The GnRH pulses from hypothalamus result in pulsatile gonadotropin secretion. First during the night, then by the day. GnRH release will lead to the FH act on the pituitary and lead to the secretions of the FHS and LH that act on the ovaries and will lead to the development, the production of the estradiol. Thyroid glands plays an active role in the maintenance of the HPA excess. Adrenal glands increases their activity of the sex steroid synthesis around about the age of the 7 years. Increased amplitude and frequency of the GnRH lead to the increased secretions of the FHS and LH that lead to the ovarian follicle development and increase in estrogen. Gonadal estrogen is responsible for the development of the uterus, vagina, vulva, and also the breast. Leptin as a peptide secreted in the adipose tissue is also involved in pubertal changes and menarche. Kisspeptin, it is a hypothalamic hormone, stimulate the release of GnRH and initiate puberty. This is a pictorial presentation of the HPA axis that usually occur at the age of the puberty. It get activated. Menarche, the onset of the first menstruations in life is called the menarche. It may occur anywhere between the 10 to 16 years, the peak time being the 13 years. It denotes an intact HPA axis, functioning ovaries, presence of responsive endometrium to the endogenous ovarian steroid, and the presence of patent uterovaginal canal. The first period is usually anovular. The ovulation may be irregular for a variable period during menarche and may take about 2 years for regular ovulation to occur. Growth, the importance of the growth hormones are important hormones that lead to the growth are the growth hormone, estrogen, insulin-like growth factors, genital organs. These are the changes that occur in the uterus from the birth to the till the age of the menopause. At the time of the birth, the uterine body and the cervix ratio is 1:2. At menarche, it is 1:1, and after that, there is an enlargement of the uterus that lead to the change in the ratio, that is 2:1. What are the vaginal changes? The cells are rich in glycogen due to the estrogen. Daudatin bacilli, which convert glycogen into the lactic acid. The vaginal pH become acidic, ranging between 4 to 5. Vulva is more reactive to the steroid hormone. The mons pubis, labia minora increases in size. Breast changes under the influence of the estrogen. There is marked proliferation of the duct system and deposition of the fat. The breast becomes prominent and round. Under the influence of progesterone, the development of the SNI increases considerably. These are the Tanner stagings of the development on the girls. Usually, Tanner staging explain the development of the breast and the pubic hairs and the axillary hair growth. This is the Tanner staging development of the breast, and then the height at the height attained growth curve showing the growth spurt. This is a pictorial presentation. Precocious puberty. Precocious puberty is reserved for the girls who exhibit any secondary sexual characteristic before the age of the 8 or menstruate before the age of the 10. It is more common in girls than boys. Causes for this are usually the gonadotropin releasing hormone dependent, 80% complete central, isosexual or true. Complete, it may be constitutional causes, juvenile, primary hypothyroidism, intracranial lesion like trauma, tumor, or infection. Incomplete means any of the one thing will be present: premature thelarche, premature puberty, and premature menarche. The causes for the precocious pseudopuberty. It is a granular ovarian causes are the any ovarian tumor, hormone secreting ovarian tumor, androblastoma, McCune-Albright syndrome, adrenal hyperplasia tumor, liver, hepatoblastoma, iatrogenic estrogen, and the androgen intake. Ictiopathology, constitution due to the premature activations of the HPA axis. This is the secretions of the gonadotropins and the gonadostroid due to the premature release of GnRH. Intracranial lesions like meningitis, encephalitis, craniopharyngioma, neurofibroma, or any tumor, hypothalamic or pineal gland, mechanoplasm is characterized by the sexual precocity. Multiple cystic bone lesion, endocrinopathy, and calf ovulate spot on the skins. It is due to the mutation in the G3 protein leading to the activations of the adenine cyclase. There is stimulations of the LH, FHS, TSH, and GH. Premature thelarchy, it is an isolated development of the breast tissue before the age of the 8 and complete commonly between the 2 to 4 years of age. Either one or both the breast may be enlarged. Premature puberty is isolated development of the axillary or the pubic hair prior to the age of 8 without other signs of precocious puberty. Premature menarche. Premature menarche is an isolated event of cyclical vaginal bleeding without any other signs of secondary sexual development. This is a pictorial presentation of a 2-year-old girl showing the development of the premature development of the breast. Indications are that indicate the precocious puberty. Diagnosis through precocious puberty. Constitutional type is the commonest. The diagnosis is made by the detailed history. Pubertal changes occurs in orderly sequence. Tanner staging. In investigations, first we have to confirm the diagnosis. So investigations are done by radiological investigation, X-ray of the hand and wrist for both age. Acceleration of growth is one of the earliest clinical features of precocious puberty. Pelvic sonography to rule out the any ovarian pathology. CT scan brain, MRI brain to exclude intracranial lesion. Hormonal assays level measure like thyroid, HS, HCG, FHS, LH, serum estradiol, testosterone, 17-hydroxyprogesterone, DHEA, dehydroepiandrosterone. Premature thelarchy. Breast bud enlarged to 2 to 4 centimeter. Somatic growth pattern is not accelerated. Bone age is not advanced. Nipple development is absent. Vaginal smear shows a negative estrogen effect. Is the characteristic features of the premature thelarchy. Now, the premature puberty, an ovarian enlargement may not be palpable clinically. Examination under anesthesia sonography is helpful. IVP or CT scan is required to detect adrenal tumor. Estimations of the serum 17-alpha hydroxyprogesterone DHEAs serum testosterone are to be done in suspected cases of adrenal mischief, hyperplasia, or the tumor. Premature menarche. The other causes of the vaginal bleeding, such as foreign body or injury, has to be accelerated. If the bleeding is cyclic, the diagnosis is confirmed. Now, the treatment to constitutional or the idiopathic type, the goal are to reduce the gonadotropin secretions, suppress the gonadal steroidogenesis, or counteract the peripheral actions of the sex steroid, to decrease the growth rate to the normal and slowing the skeletal maturation, to protect the girl from the sex abuse or the sexual abuse. Assessment of the speed of maturation process. Drugs used are GnRH agonist therapy is the drug of choice in case with GnRH dependent precocious puberty. It suppresses the FHS LH secretion, reserves the ovarian cycle, establishes menorrhea, causes regression of the breast, pubic hair changes, and the other secondary sexual characteristics. Doses are bisvalerian nasal spray 100 mg daily. Depot forms goosevarian leoprolide once a month. Dose is adjusted to maintain the serum estradiol level below the 10 picogram per ml. Medroxyprogesterone acetate 30 mg daily orally or 100 to 200 mg IM weekly to suppress the gonadal steroid. Cyproterone acetate, it acts as a potent progesterone agonist, effects on progesterone receptor. Dose 70 to 100 mg per meters surface area day per day orally for 10 days starting from 5th day of cycle. It produces the amenorrhea and breast development. Duration of therapy up to the age of the 11 year. Prognosis is usually dependent on the ecology. Now, the delayed puberty. Puberty is said to be delayed when the breast tissue or the pubic hair have not been appeared by the 13 to 14 years, or menarche appears as late as the 16 years. Delayed menarche. Before the onset of the menarche, pubertal changes of the breast budding followed within the few months by appearance of the pubic hair. Breast budding is the earliest signs and the menarche is the latest signs of the puberty. Causes hypogonadotrophic hypogonadism, gonadal dysgenesis, pure gonadal dysgenesis, ovarian failure, hypogonadotrophic hypogonadism, constitutional delay, chronic illness, malnutrition, primary hypothyroidism, isolated gonadotrophin deficiency, intracranial lesions, tumor, craniopharyngeal, pituitary adenomas, eugonadism, anatomical causes, Mullerian agenesis, imperforate hymen, transvaginal septum, androgen insensitivity tumor. Diagnosis, estimation of the secondary sexual characteristics, which are evaluated for the evaluation of the Mullerian agenesis, asynchronous development of breast and the pubic hair, immature secondary sexual characteristic, serum, FHS, prolactin, thyroid, and the TPO, CT scan, Treatment is usually depend on the ectology. Cause cases with the hypogonadism may be treated with the cyclical estrogen, unopposed estrogen 0.3 milligram conjugated estrogen daily is given for the first 6 months. Then combined estrogen and progesterone sequential regimen is started. Causes of the hypogonadotrophy and hypogonadism should have the chromosomal study. Now the puberty menorrhagia. Menstrual abnormality in adolescent are common. The periods may be heavy, irregular, scanty initially. Causes of menorrhagia: dysfunctional uterine bleeding, endocrine dysfunction, maybe PCOS, hypothyroidism, hematological. It may be idiopathic, or idiopathic thrombocytopenic purpura, von Willebrand disease, leukemia, etc. Pelvic tumors, any fibroid, sarcoma, botroids, estrogen producing ovarian tumor, pregnancy complications. Diagnosis made by the detailed history taking and the examination. Investigation include the routine hematological examination, including bleeding time, clotting time, platelet, thyroid profile, clotting profile, ultrasonography, and examination under anesthesia. These are pictorial presentations for the management of the puberty menorrhagia. First, we have to counsel the patient. We'll have to give the hematinics to overcome the anemia, and assurance has to be given. Heavy bleeding, if the continues, then patient is admitted for the investigations. What kind of investigation we would like to do? Like we have to do the hemoglobin, complete blood count, peripheral smear, to for any coagulopathy, clotting factor studies, sonography for any pelvic pathology, thyroid profile, blood transfusion if required. Now, if primary and secondary, now the puberty menorrhagia may be primary, that is DOP without any functional, any pathological causes. Progesterone, that is medroxy progesterone, can be given. If it is responsible, we have to continue this for the 2 to 3 cycles. If it is unresponsive, then we can give the estrogen therapy. That will be the conjugated estrogen. If it is response, then we have to give combined oral pills containing 50 micrograms of estrogen. If unresponsive, then examination under anesthesia and DNC and the biopsy taken and the treatment then according to the cause. If it is secondary to any pathology, then the treatment of the cause has to be done. Thank you.